We are running a bit behind schedule, so we'll move on to the next session now on critical care medicine and rehabilitation. For the next session, I'd like to invite on stage the chairpersons, Dr. Rimita D. Ma'am, Senior Consultant and Head of the Department of Critical Care Unit, Ruby General Hospital, and Professor Dr. Shubhashree Bandyopadhyay, Department of Pharmacology, KPC Medical College and Hospital. I request on stage the first speaker for this session, Professor Dr. Sugata Dasgupta, Department of Critical Care Medicine, IPGMER and SSKM Hospital.
Good afternoon. I thank you, Dr. Shapon Misro and Dr. Postop, for inviting me in this August gathering. Myself from a different specialty, but talking on a subject which is very close to my heart. Before that, I just want to give a small introduction of myself. I was trained in critical care medicine from Brichkandy Hospital, Mumbai. I was then trained abroad. After that, I returned to the government sector of West Bengal to develop the specialty of critical care medicine for the poor and the needy. So, I probably started the specialty of critical care medicine in the government sector. And right now we have around 80 basic level critical care units, basic level throughout the districts of West Bengal. DM courses in critical care medicine at my place. And in Arjikar Medical College, I worked for 10 years, and probably who have been associated, we have our beloved Professor Bandyopadhyay, who was our MSVP at that point of time. He knows they all supported me to develop a system of critical care, which was till then totally unknown to the government sector of West Bengal. So probably I have some experiences to talk in this topic of critical care, importance of physical medicine and rehabilitation in the critical care scenario. I have a complaint to the all physiatrists over here. In the last session, which was chaired by Professor Manos Bandyopadhyay, DME sir, senior physiatrist, I didn't hear a single word about critical care physiotherapy or physical medicine. We all concentrated on orthopedics and PMR. We all concentrated on rehabilitation in the long term, but still probably we left out a huge area, that is intensive care unit and acute care. And I think, as my writing goes, critical care without PMR support and without critical ICU rehab is absolutely bogus. Absolutely, there is no meaning. It is no critical care. So when I started in government hospital, I had no dietitian. I had only the physical medicine department sir is there. They were there to support me. But they were also overworked by OPD cases. Their faculty numbers were quite low. All of us are quite overloaded and overworked in government hospitals, so that the support of PMR for acute care and critical care is always lacking, because they also don't have any options to provide us with the support for the inpatient care, because they are overburdened with the outpatient care. So I became a physiotherapy person, I became a dietitian, I became a group D staff, I became a transport person, and that was the way it started. So things are developing now, and probably we have now DM students, seats are increasing next year also. So this is the journey of, so that's why this session is just about the importance of PMR. I am not a specialty from a PMR, so I don't want to give any didactic lecture on the importance of PMR in critical care or physiotherapy. So I just, critical care or acute care. So I just want to highlight some areas where we are still lacking behind. And really, I take this opportunity to put this appeal forward to all the senior faculties of physical medicine and rehabilitation, just to take up this issue also. as I will request the all faculties just to also put focus on developing the critical care PMR facilities so that the lives are much more saved in the long-term outcome. Long-term outcomes are better. So that's why this will be my appeal to the whole physiatry association over here. So I was talking about 2005 when I went to Bombay. I started the critical care setup in 2010-11 in Arjikar Medical College, and I used to mobilize patients and I used to go for these things. Yes, at that point of time, probably not much data had come up. While preparing for this talk, I found that the most of the data on the importance of physical medicine and early mobilization, rehabilitation in critical care have started to come from 2008 to 2020. And the guidelines have started to come out in 2021, 22, 23, 24. See, it's only 4 or 5 years where in Australian guidelines have come up, German guidelines have come up, Russian guidelines have come up, Japanese guidelines have come up. But it has to be remembered that we were practicing that 15 years back, but we didn't publish because we didn't have the manpower and the support of the system to make us feel about the importance of physical medicine, critical care. So that is my appeal to the society from here. So this consciousness of the importance of PMR in critical care and acute care is the need of the hour, and it has to be realized. And I will request this gathering just to percolate this among your students, among the other juniors, and among the fellow colleagues. So choosing wisely for critical care, the next 5 there was a movement with us to decrease the cost of critical care, and choosing wisely came in around 2017-18. So there were 5 things of choosing wisely to decrease the cost of critical care. But after then, the next 5 came, where another 5 interventions came to decrease the cost of critical care. And here came, don't delay mobilizing ICU patients. So we all know that early mobilization is the only thing which we need. But do we have the manpower? I don't have the expertise. I don't have the training to execute the proper scientific mobilization like PMR professionals. But I have to do because I have no other way, because the community of physiatry is also small. The residents are small. There are no SRs. They are also overworked with OPD patients. They cannot support me. Sir was working with me in Arjikar Medical College. He has told me several times, আমার কোনো লোক নেই, আমি দিতে পারছি না, আমি জানি তোমার দরকার, আমি দিতে পারছি না. So this is the scenario. So the importance of PMR in acute care or in critical care does not needs to be emphasized. So what are the aspects of, and it should be remembered that this is a team care. This is a team care. There are, so once a patient is ventilated, there are 4 things which need to be segregated. One is positioning, one is mobilization, one is rehabilitation, another is swallowing. So yes, Kaustubh will say that he has speech therapists at Peerless Hospital. I don't have. So I have to I have to check the patient whether enteral oral feeding the patient is able to take tolerate the oral feeding or not. So I have to check it. So when I was training in Australia, video endoscopy and video fluoroscopy was the test which was used by speech therapists to assess the swallowing. But recently, while preparing for this talk, I came from the German guidelines which came out in 2024. They say that video endoscopy and video fluoroscopy is not needed. It's expensive. Clinical assessment of swallowing with 3 ounces of semi-solid material is the recommended thing which they have recommended. So which we were doing, but we didn't publish because the consciousness about the rehabilitation, swallowing rehabilitation, things in intensive care in India, in West Bengal, and in our setup, even in the government setup, even in private setups. I work in private, I do some consultations in private. The scenario is the same. Yes, the scenario is the same. The scenario is not very different. Everybody is overstretched, and everybody is overstretched. So So these things need to be, and along with that, the physiatrists also have to have an idea about the critical care nutrition and the PADIS guidelines of pain, agitation, delirium, immobility, and sedation, which will have a very close relationship with the whole process of positioning, mobilization, rehabilitation, and swallowing. So what were the positive effects of these PMR interventions in critical care? Decreased pressure source, yes. Early weaning from ventilation, that is the important thing. That is the important thing. The more and more the ventilation, the more and more are infective complications, the more and more are ventilator-associated pneumonias, and the length of ICU stay, length of hospital stay, and you go into a vicious cycle. Decreased delirium. This is not only hyperactive delirium, but also hypoactive delirium. Decreased ICU acquired weakness. This includes CIMN, critical illness myoneuropathy, polyneuropathy, polymyoneuropathy, everything. So it's a new conglomerated term, ICU acquired weakness. Post-intensive care syndrome. I have some publications on post-intensive care syndrome where PMR has a huge role in preventing and treating PICS. Post-ICU activities of daily living, post-ICU quality of life, decreasing ICU length of stay, decreasing hospital length of stay, thereby decreasing ICU acquired and hospital acquired infections, preventing ICU readmissions, thereby everything decreases the cost of health care. Yes, the physical medicine interventions may not have effect on immediate mortality or immediate survival, but studies have shown that these things have effect on long-term survival at 180 days, at 6 months. That is important in our society. We were talking about society. I just put an appeal also to include this group of critically ill patients who go into the society with various complications of intensive care. Post-intensive care syndrome, delirium, ICU acquired weakness, and everything, where PMR is the only solution. So the ABCDEF approach, we all learnt about ABCD, airway, breathing, circulation, disability. But this is the approach of ICU rehabilitation: awakening, breathing, coordination, delirium, exercises, early mobilization, and family engagement. So with these, So by this, yes, ICU admission. After that, the ICU stay, ICU discharge, and follow up. The importance of PMR is through the whole spectrum. But I am sorry to say, in our system, this doesn't happen. This doesn't happen, and that's why our mother, our fathers, our grandfathers, they also have these types of length of stays, increased costs, unnecessary infections, unnecessary complications, and maybe mortality after 5 months of discharge from ICU. There are some barriers. There are lack of qualified and dedicated ICU PMR professionals. Yes, dedicated means they are dedicated to the ICU. I have to say that ICU critical care is not paying. ICU critical care is ICU PMR is not paying. OPD PMR is much more paying than intensive care PMR. So that's why the physiatrists are also probably much more inclined towards OPD practice. But where do we go if you don't support us? So where do we go? Because we have to give results. So lack of qualified and dedicated intensivists also. All intensive care do not have the idea of the importance of PMR. That is dangerous. Lack of awareness of training and exposure of primary consultants. Sir was telling, this is very much there. Many people think that positioning a patient is below their dignity. Suctioning a patient is below their dignity. No, that doesn't make an intensive care practice successful. So you have to do everything. You have to know everything. You have to know everything practically. Then only you can motivate a team. You can ultimately make a team perform. Lack of adequate autonomy and recognition to PMR professionals or even intensivists in open ICUs of India. Lack of authority or ownership of PMR for ICU patients. Yes, you own the patients in your clinics, but probably you don't own the patient in the ICU. These are small factors that also implies to me also, of my colleagues who work in open ICUs. Yes, there are.
lack of continuity of care. Once the patient goes out of in government hospitals, a patient whom I shift from the ICU to the ward, those patients are almost ICU patients for private hospitals. So they also need physical medicine and rehab support in the wards too. And they need to be followed in your OPDs. So you need also indoor beds. So this continuity of care doesn't happen. Concerns regarding safety of mobilization. I have trained a few PMR guys. Yes, they were physiotherapists. They used to come to me just to have 1 year of exposure to critical care, so that they gain the confidence of handling patients with endotracheal tubes and lines and everything. So usually, few years back, some physiotherapists used to come, and they are doing well in private. Lack of training and exposure of PMR and ICU professionals, poor ICU practice, culture and protocols, no touch intensivists or clinicians, and yes, quality of evidences supporting benefit are very varied in early mobilization. They are very varied, but all the guidelines have told এটা লাগবে এইটুকুন আমি যে বুঝেছি পড়ে, what I could make out, that if we move patients early, then we do not do any harm. But if we do not move patients early, then we do a harm. So it's better to move patients early, just to go for. So with these in 2020, as first systematic review came, and these were the key messages. Early mobilization is safe. Early mobilization may reduce healthcare costs. Safety criteria should be provided. A protocolized structure should be used. A collaborative teamwork is required between intensivists and physiotherapists and everybody. Staff requires specific skills or experience. Family engagement is important. And a consciousness about the nutrition and PADI's guideline for the physiatrists is also important. And here, so over the last 4 years, many guidelines came. The Australian guideline came last year, in this year, 2025. The German guideline came in 2024. The Japanese guideline came in 2023. The Russian guideline came in 2022. So everything is coming in last 3 or 4 years. But we have been thinking of these. We have been practicing these in a sub Neanderthal scenario probably 15 years ago. I just put this appeal to all physiatrists to help us improve the quality of care of critical care physiotherapy to a appreciable level. So we cannot reach this. So this is neuromuscular electrical stimulation for patients who cannot be mobilized in the first few days of the ICU. This is cycle ergometry. So this is NEMS plus cycle ergometry. This is tiltable. Yes, these were, when I was training in Australia, yes, these were there. But we have to be very practical. What we can do, where we can deliver these types of mobilization and rehabilitation treatments to our patients. This was a Times of India thing which came out in 2017. So now they have included ABCDEF, where family involvement in mobilizing patient there from 2013-14, and this hospital engages skin for post-ICU rehab. This was one of our patients from Arjikar Medical College ICU. So we are left with all clinical things. So it is yesterday, a patient with lupus, a very young girl with lupus coming out of a macrophage activating syndrome. This is the poor father and mother which trying to help the person to rehabilitate. So I have left with no other options but to involve the family. Herein, I just put my appeal toward the physiatrist community just to build the system to help us better in critical care to deliver better results. So critical care without rehab is no critical care, and the ABCDEF approach is the key. Thank you.
Thank you, Professor Shubhu. Wonderful.
Yes, sir.